hormone replacement therapy was developed in the 40s, 50s, 60s, through that pathway, simply to get rid of hot flashes. Forever, we defined menopause symptoms by the presence or absence of vasomotor symptoms. But that was it. There was no talk around the brain changes, which led to mental health and cognition changes, the musculoskeletal changes, which, with your background, you probably know what better than anyone with arthralgias, arthritis, oh my God, frozen shoulder, all of that. Besides
frozen
skin,
shoulder,
hair, teeth, gut, every single organ system in our body is affected. And the old guard, who wrote the papers on vasomotor symptoms, who really defined menopause by, and everything else that we are going through at this age was attributed to aging. Nothing to do with hormone depletion.
Dr. Mindy here.
Your body is in a war zone.
Different parts of the brain get activated depending upon how stressed you are.
When you look at it from that inflammatory.
It's interesting. I mean, that has some merit to it for sure.
And you can't control everything.
I'd say.
And what about a woman who is not pregnant, but she's aiming?
Okay, well, let me just start by welcoming you, Dr. Haber. Your work has inspired me. I have been watching you do your Facebook's lives and all your videos. And as somebody who puts out a lot of video content, I know how hard it is. I can feel your passion and I feel your heart for what you're trying to do for women. So I just want to welcome you to my podcast and say thank you. I can't wait to have this conversation with you.
I'm just so excited to be here because, again, I've been watching you, following you, and just love your communication style and how effective you are at inspiring women to look at themselves, habits, changes so that they can live a healthier life and not accept the status quo. So, yeah let's do this.
Yeah, let's do it. So I'm going to start this off with over the last couple of days, I've been diving into your book, and I got to tell you that one of the threads of thought that keeps coming to me is we needed this book. Like, I'm 54. I needed this book when I was 40. I know when I was in practice working with lifestyle with women, like this book was needed 20, 30 years ago. And I'm so happy you wrote it now and the lens from which you wrote it from. But I also feel like there's this cracking open of a cultural conversation that's happening around menopause. There's like an empowered feeling that women are starting to embrace because of books like this. So what is it that's happening in this moment around the conversation of menopause that wasn't happening decades ago?
When I look at the options that our mothers and grandmothers had, and when they got to our age in their 50s, it was like, this is as good as it's going to get. And they just calmly accepted what the world offered to them by and large, which ended up with them having 20% of their lives spent in poorer health than their male counterparts, 3 to 4 times higher risk of Alzheimer's, much higher risk of fragility, and ending up 3 to 1 needing long-term care facilities for extended period of times more than their male counterparts. Our generation, the elder millennials and the Gen Xers like us, because I'm 55, are saying absolutely not. Like, this is not okay. And how we approach, study, and conceptualize our menopause, which is from the last menstrual period until we die, okay? They know that if we just stay on the path that has been laid out for us by society, by how medicine treats us as females as we age, is going to lead to these poorer outcomes, and we're not willing to put up with it. And this is the exciting part of what I'm doing is, yes, I'm getting some pushback from the establishment. You know what? That's okay. Take me out for it. I don't care,
Yes,
because I know that we are the menopause. The messages that we're giving women that are resonating with them are leading to change in their habits and health and options that are going to lead to better quality of life as they age.
Yeah. I so agree with you that there's, like, I keep saying to many of the health people in the health world that are educating women, I keep saying, can you feel it? Do you feel it? Like there's something going on. There's something inside women that we are now being like, no more. You
No
can't
more.
treat me like this. You can't gaslight me in an office. You can't give me an antidepressant for my menopausal symptoms. There's like this real rising up. And I call it, what I've been phrasing it is the patriarchal hex, that women have been under this sort of hex of accepting mediocrity in when it comes to our healthcare system. And by patriarch, I always want to say it's power over, it's not men. I have
some of the loudest voices that are the status quo are female. So I want to be very clear. This has nothing to do with men.
Right.
Women are probably the worst at trying to continue a narrative, at least in my world. And we're just not standing for it.
Yeah. 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 And so with that in mind, I really want to move into in this conversation, when you look at the symptoms of menopause, what I see that gets highlighted and profiled and media grabs onto, although this is changing, is hot flashes.
Right.
But I can tell you, as a 54-year-old woman, like hot flashes it was a thing. But can we talk about the mental changes that happen throughout the menopausal journey? Because those were the changes that were affecting every relationship in my life. So when I look at the research and about how these estrogen receptor sites are still very active in us post-menopausal through what is that telling us about menopause and how we need to do it different?
Okay. So let's back up to the first part of your statement of, forever it seemed like menopause treatment was defined by hot flashes. You are 100% right. Hormone replacement therapy was developed in the 40s, 50s, 60s, through that pathway, simply to get rid of hot flashes. Forever, we defined menopause symptoms by the presence or absence of vasomotor symptoms. 85% of us have them. For 20, 25, 30% of us, they're severe and life disrupting. But that was it. There was no talk around the brain changes, which led to mental health and cognition changes, the musculoskeletal changes, which, with your background, you probably know what better than anyone with arthralgias, arthritis, oh my God, frozen shoulder, all of that. Besides
frozen
skin,
shoulder,
hair, teeth, gut,
Yep.
Every single organ system in our body is affected. And the old guard, who wrote the papers on vasomotor symptoms, who really defined menopause by, and everything else that we are going through at this age was attributed to aging. Nothing to do with hormone depletion. And that's where the new research is going. So the beautiful study that just got published in Nature magazine by our friend, Dr. Lisa Mosconi, who's a neuroscientist who in her entire career has studied the female brain and its relation to dementia and Alzheimer's. Okay, that is what she does. She PET scans brains left and right. She's at Will Cornell. She's amazing. She is the first person in history to look at the female brain by PET scan through the menopause transition, menopause brains, and looked at the activity of estrogen receptors. And what we thought was estrogen receptors kind of fall off and die as we go through menopause. No, they actually upregulate. The brain is starving for estrogen. It's creating its own estrogen through peripheral conversion, of estrone to estradiol and some testosterone. It is dying for estrogen. And so the brain, parts of the brain, the hypothalamus, pituitary, the functioning, the cognition, the memory centers are lighting up like firecrackers in postmenopause because the estrogen receptors are like, help me, we need estrogen.
Yep.
The old guard attributed we know that women are having cognition changes through menopause. They only attribute that to the loss of sleep from vasomotor disturbance. Lisa proved them dead wrong. This is literally due to the loss of estrogen in the brain that lubricates and makes everything work better. And we take that away and the brain stops dysfunctioning, all stops functioning normally. Also, we know, great research coming out of Australia, we have a 40% increased risk of mental health disorders through the menopause transition. So in perimenopause, when the levels become chaotic before they plummet, in postmenopause, that's when we see the biggest disruptions to our mental health.
Yep.
And forever that got dismissed as this is a time in your life. You're stressed out. Teenagers are driving you crazy. Your parents are getting older. Your job is more demanding. You're not, no, it is literally the disruption of neurotransmitters in our brains due to the chaotic fluctuations of our hormone levels. And here's the third thing that Lisa's discovered, and I've seen it also in the liver literature. FSH, as we know, right, follicular stimulating hormone, which is made in our pituitary that makes us ovulate, basically, to simplify it. FSH rises in perimenopause and then gets really high in postmenopause and stays there for the rest of our life. New data is showing that those FSH alone, without the estrogen depletion, is toxic to the liver and the brain, increases the rate of Alzheimer's plaques, in the brain. Just the FSH elevations. And if we can get those FSH levels down, those processes get easier. I mean, it's just explosive what's happening right now in the menopause world. I'm so excited.
Yeah. So there's such a great explanation. So does that mean that everybody should go on hormone replacement therapy?
No, that means that everyone deserves an informed conversation about the particular benefits of hormone replacement therapy and how it may affect her life. I don't think it's for everyone. No, it's a medication. You need a full discussion of the risks and benefits. But what's happening in modern medicine is that a woman walks in with hot flashes. So classic vasomotor symptoms. She has a 10% chance of getting the diagnosis of menopause put on her chart. No periods.
It's a it's a diagnosis. Wait, I don't even that right. Seems so like a fun
10%. So in that 10%, if she's offered treatment, 4-to-1, it's an antidepressant versus menopause hormone therapy. Only 6 to 7, depending on who you read, 6 to 8%, depending, because we don't track the compounding pharmacies, right? So it's only the FDA approved stuff. But right now it's 4 to 5% are getting FDA approved HRT medications of women who are eligible.
Yep.
So do I think all women need it or want it or whatever? No, but I think everyone deserves an informed conversation, not only about the risks, and not only about hot flashes, but about the cardioprotective and neuroprotective benefits.
Yeah, I love that thought. And the way you phrased it is that every woman deserves an informed conversation, which is amazing. Now, I will tell you what I've seen, not only in my clinical practice, but in our online community, is that there's no one size fits all when it comes to HRT.
Right.
And we can't, and this is what I love about your books is like, and this is the lens in which I see things, is we can't leave lifestyle out of this conversation. No. So what I just want to make sure the women that are listening to this is, as exciting as this is, it doesn't mean you put a patch on and life's going to be like how it was at 30.
I wish.
Right.
I mean, I've had to completely overhaul my nutrition, my movement strategies, my stress reduction, my boundaries, I think I'm like you in that, I'm 55, I'll be 56 in about a month. I literally am living my best life. I have
me too.
Better relationships,
better
intimacy, better health.
Yes.
I'm wealthier. I'm helping more women than I've ever helped in my life. Super proud of my past and everything I've done. But this is it. And I want everyone to feel that way, right? At my age and beyond. But had I not overhauled how I eat, how I think, how I move, my pharmacological choices, I wouldn't be here today.
Yes. Amen to that. And here's what I love about my conversation with Lisa that's bleeding into this conversation is that as I was going through my perimenopausal years, I kept trying to figure out what's going on with my brain. And I brought guests on to my podcast, one of which was Dr. Amen, who I love. But when I asked him what's going on with the female brain, he said, well, it was because you weren't meant to live that long. And I thought, well, that's a horrible answer. I think I want to live to 100. So that's a horrible answer. So when I brought Lisa on, she talked about how the brain changes and brought up this idea of the grandmother hypothesis and how our brain actually becomes a more highly functioning brain post-menopausal years. That amygdala calms down. It starts to be more empathetic. We can see the bigger picture. And when I saw that, my brain was like, so basically the brain changes that are happening in menopause are setting us up to be cultural leaders. That women in their postmenopausal years are their absolute best, to your point, living their best lives.
Mm-hmm.
But that's not the message that's getting sent down to women.
No, it's like you're developing Alzheimer's at a higher rate because you live longer, and that is not true. That is absolute false.
Yes. So if we were to take a woman at 40 and say, here's what's coming down the road, here's what I recommend you do so that you can land at 55 and 54 where I'm at, and we both are at, living your best life, what advice would you give?
So I have a little talk that I do that's like what I would tell my 35-year-old self. So roughly the same thing. Nutrition over calories. You know, this whole cultural, I grew up with it. My whole life, I worked out to be thin and I ate to be thin. Those were my two goals because thin meant healthy. Okay. Certainly being thin is more healthy than being morbidly obese. My genetics was never going to allow that to happen to me. It'd be almost impossible. Okay. To be morbidly obese. So I have been privileged for that. But I just focused on calorie counts. That's all they taught me in medical school. I knew about kwashiorkor and scurvy and severe vitamin deficiencies and stuff, but basic day-to-day nutrition, I went back to school at like 48 to learn about nutrition.
Wow.
And then incorporate that into my practice, which, then I wrote into a book. But so, really focusing on nutrition over calories. Are you getting enough fiber? So like I have a few tenets that I focus on. Foods rich in fiber also are rich in so many other things, vitamins, minerals, nutrients, so it's like you're killing multiple birds with one stone. But most women in the US are only getting about 10 grams of fiber per day. Great studies coming out looking at cognition and fiber intake, in elderly patients, looking at fiber intake and gut health. I mean, we all, most of us know that now. And so women should be getting minimum 25. The health benefits for at least cognition seem to max out around 32 grams per day. That's 3 times what most women are getting. So nuts, seeds, legumes, crunchy vegetables, fiber, berries, getting food rich in that rather than just like, oh, low cal, like how much fiber are you getting?
Yes.
How much magnesium are you getting? What's your vitamin D level? Like looking at those things and the rest kind of falls into place. And then you go from a place of restriction to a place of, I got to eat more. Are you getting enough protein? Oh my gosh. Like I was not getting enough protein.
Yeah.
For sure.
What are your recommendations on protein? Because we've had some really deep discussions on this in my membership group, and people are struggling to get 1 gram of protein for every pound of body weight.
So again, there's a big mental shift that has to happen. It had to happen for me. But when we look at the WHI, the Women's Health Initiative, which kind of threw out estrogen as an, optimal treatment, it's just a data set. There's really good data that came out of there. For example, they looked at fragility scores in menopausal women and protein intake. And the women who had the highest level of protein intake, about 1.4 to 1.8 grams per kilogram of lean body mass. So just under 1 per pound. Just looking at that, had lower fragility scores. We are not eating enough protein to counteract the sarcopenia of aging. Yeah. And so upping your protein. So I'm recommending for my patients, and I do it in kilograms. I have a body scanner in my office. I measure their muscle mass. I look at their visceral fat. And, I'm really pushing closer to that 1 gram per pound, of healthy body weight. Yeah. And because they're usually about 50 or 60. So I'm like, don't do this tomorrow. This is a transition. Okay. So we're going to, don't think you have to fix everything today. You've been living this way. We're just going to get you, let's make our goal by the end of the year. We have a 6 months to a year. Let's get you up. And so every month you're going to try to increase here, increase there. And, protein supplements can be a great segue to get there. I always prefer you to get your protein through food. Supplements are great, but they don't replace whole food and good nutrition. Yeah. And so, for my patients who are transitioning to get to these higher levels, sometimes a protein shake or some of the bars can be a great way to help them until they figure out how to incorporate more of the protein rich foods in their diet.
What would you say to the vegan?
It's tough. It's possible, but it's tough. Right? You can be healthy without HRT for the rest of your life. It's tough. It's harder. And so, all of these are not absolutes, but if you choose to be vegan, it's definitely healthier than the Western diet. We know that. Of course. But you're going to struggle. It's going to be harder for you to get the recommended amount of protein to avoid the frailty as you get older. You know, the goal is not to be thin. The goal is to stay out of a nursing home.
Oh my God, that's so that you need to say that
is what I
rooftops.
talk to my patients all day long. I'm like, let's get rid of the acute problems. Let's get rid of the hot flashes, the night sweats, the brain fog, those things that brought you here. And then we're going to set a course for the next 30 years. Okay. Yes. And what are your goals? What does your mom look like? And look, if their mom is kicking ass at 95 and going to the grocery store and driving herself and playing with grandkids, I'm like, let's do what she does. Okay.
Yes.
But if your mom, like mine, is frail and demented at 80, I'm like, we're not going to do what she did. Let's look at what we can change, you know, because that's your genetics.
Yeah. I love that. Okay. So that number one is nutrition. What, anything
movement.
else?
Okay. So movement. All right. I worked out to be thin. Cardio, pick up some weights. We cannot counteract the effects of sarcopenia of aging without resistance training, most of us. Yeah. And so the majority of what I do is not focused on cardio. I do some cardio, of course. You know, I have a walking gym. My treadmill is a working desk. And so I walk while I work on an incline with my weighted vest. So I love the weighted vest as a hack. They're cheap. They have multiple sizes. You want to start with about 10%, but great studies done in the elderly of us, you know, which is 9 years away for me, by the way. And looking at prevention, like improvement in their balance, in their strength, and in their bone density scores. Great data on weighted vests with protein intake, sometimes vibratory training. There's lots of little hacks and things that we can do, but like really focusing on strong over skinny.
Yeah. Oh, I love that.
Strong over skinny.
I just got a weighted vest. I just told my husband this morning, I'm like, I'm a wrecker now. And he's like, what? Like, yeah, I'm going to start wrecking. I'm like, it even has a fancy fun name.
It's a form of wrecking. I like that it distributes the weight evenly over the shoulders rather than just all on your back. And so my husband is all into it now. So we have like 6 of them. So in different levels.
How much? So I can tell you in putting my own exercise variation together that I've definitely found weightlifting to be great, but I've also found walking to be incredible, especially when my brain's on fire. So what would give us a view of what like a week would look like as far as exercise variation?
Sure. So I recommend to my patients, for as far as cardio goes, we want about 150 minutes a week. That seems to be kind of the tipping point. And most of that in zone 2, a little bit, you know, do a few sprints here and there. You don't have to do much to get the VO2 max up. So like shoot for about 150 minutes a week of cardio. So that's like 5 walking sessions for 30 minutes a week, or 45 minutes if you have to crunch it down. And then 2 to 3 days of progressive load resistance training, a push day, a pull day, you know, just making sure you're hitting everything. Don't forget about stretching and don't forget about balance. You know, those are the things that are going to decrease our risk of an osteoporotic fracture. And so, you know, if that happens, go ahead.
No, and what about yoga? Because like Sarah Gottfried's
yoga,
a good
depending
friend.
on the type, stretching, balance, and if you're doing a lot of vinyasa and, you know, you're getting a lot of, you know, you see yoga arms all the time. You know, these women are ripped. And so again, yoga can be fantastic for relaxation, for stress reduction. It's just, we must also push our muscles. So you have to do the more aggressive forms of yoga to get that to happen.
Okay, great. Okay, so second is movement. Mm-hmm. What's after that?
So nutrition, you know, strong over skinny, nutrition over calories, educate yourself, you know, learn. Our books, you know, there's so much great information out there, websites, whatever, you know, and realize you don't have to accept the status quo. But if you probably don't change the habits you've got right now at 30, for most of us, this is not going to go as well as it could for you through this aging process.
Yes.
You know, that includes menopause.
Yes.
And, you know,
agreed.
Changing your mindset around how you look to how you feel. And so looks are important again, but it should not be the primary driver of the choices for your health.
Yeah, I continually say that I feel like I'm partnering with my 100-year-old self. Like literally every day, I'm like, what do I need to do today to make my 100-year-old self proud? And if I always keep her in mind in my day-to-day, I know I'm going to love 100 when I get there. So I like where you're going with your thought process on that. Mm-hmm. What about fasting? We have to bring fasting up.
So no, I love fasting for the anti-inflammatory benefits. Those are clear. It's very, neuroinflammation, we have great data. Systemic inflammation, we have great data. Where my patients are struggling as we're aging is protein. And so myself, I used to break my fast at noon, typically. What time is it? Yeah. And I bumped my window back about 2 hours so I can have enough time to get the protein in, and I'm not walking around all day with a chicken breast, in my hand.
Yes.
And so gnawing on a chicken breast. And so, I
Yeah.
feel like I'm still getting the benefits, the anti-inflammatory benefits. The data for weight loss is not great. And again, I'm not focusing on just being thin as a measure of health, and I'm discussing that with my patients.
Right.
But I do think there's a place for it, and there's, some great data on anti-inflammatory benefits.
Yeah, and what Lisa and I discussed is what we've seen, and she's seen this, I've seen this, where something about the ketone. In fact, I keep diving into does the ketone actually activate one of the estrogen receptor sites? Because something happens when when a menopausal woman has a ketone going through her body, that the brain fog's gone, the mental clarity and focus is back. And she agreed, but I said, well, where's the research on that? She goes, unfortunately, we don't have any.
We don't have it.
But have you experienced that?
For sure. I mean, in my personal life, I fast in the morning. Is after my sleep, and so I just keep going, and I am absolutely my most productive in the morning. Again, it's quieter. I'm an empty nester now. There's lots of things feeding into it, but I am doing my best work, my best writing, my best reading, researching in those fasting hours for sure, hands down. And many of my patients say the same thing.
Yeah, yeah. So I think we can debate fasting lengths and protein, all that. And then I really lately have been we can't stop talking about the ketone for menopausal women, just a small amount, because it does seem to supercharge the brain in a really unique way. So another concept that I've been thinking a lot about is the different rhythms that women put themselves in. So one of those rhythms being the circadian rhythm. So I'll give you an example. I have a good friend who's in her early 40s. She just spent 6 months traveling from many crazy different time zones, and her whole cycle is completely off. So she meanders into her OB's office yesterday, and there's a conversation about, do we have to adapt your HRT? And one of the things I kept saying to her is, you just took yourself out of your own circadian rhythm. Bring a routine back to your circadian rhythm, and then see what's necessary in the changes of your HRT. So where does circadian rhythm fit into a woman's hormonal rhythm?
There's definitely a relation, because melanocortin, I mean, we know, and melatonin, the natural melatonin, and all of these little hormones talk to each other in the hypothalamus and the pituitary. And so we're not studying women. We're not studying female animals in the labs, because of this exact thing. All of these rhythms are disrupted as our hormone cycle change when we're pre and perimenopausal, and it makes us harder to study. So they're like, she's just a small dude with breasts. Let's just study the men. And so we need more research here. And I'm not saying that absence of evidence isn't, and I think Peter says this the best, absence of evidence is not evidence of absence. Yeah. I just can't go around recommending things off the bat without, this is something that would be fascinating to look at.
Right.
I definitely think there's a correlation.
Yeah. So, and then that also leads me to the nervous system rhythm. And this was something that actually came up the first time I went on Diary of the CEO, is I made a bold statement that women need more rest. And I got a lot of
great data coming out
mixed
now,
results.
Right?
Yeah. I got a lot of mixed back at me. A lot of feminist women were appalled that I said women needed more rest. But what I know about the nervous system is you're stuck in fight or flight, and your hormonal system is shutting down. So where does rest and recovery have to be highlighted in the menopausal experience?
So we are in perimenopause. We are in a zone of chaos. Okay. The normal signals that used to cause ovulation, we become resistant to, because we are losing our egg supply. We're born with all of our eggs. Okay. They last us until we go through menopause. perimenopause begins when we reach some critical threshold in the quality and quantity of our egg supply. So in general, by the time we're 40, we're down. By the time we're 30, we're down to about 10% of our egg supply. By the time we're 40, we're down to about 3%, just to give you perspective. And at birth, we have 1 to 2 million eggs. So here we go. So the normal signals that the follicular cells that surround our eggs create the pathway to make estradiol and testosterone. And so LH and FSH, each month when we're premenopausal, we get this EKG-like, very predictable rise and fall of our hormone levels if you're healthy, if you're in the same time zone, if you're, like if all the planets line up, on day 14, this is going to happen, day 15, day 16, and on and on and on. The whole cycle repeats itself. Okay. That is how God made us. That is the perfect way, right?
Yeah.
Now we hit perimenopause. We reach that critical threshold. So the hypothalamus is constantly sensing until we die, looking for estradiol in the blood. When it doesn't see it, or when the levels drop, it sends the signal to the pituitary through GnRH to say, tell the ovary to make the estradiol. We're running low. LH and FSH start pulsing out of the pituitary gland, talking to the ovary. The ovary's like, I can't respond. I don't have enough eggs left. So the hypothalamus says, hey, where's the estrogen? Come on. Send the signal. Pituitary said I did. And it says send more. That's where we see the rises of our FSH level in perimenopause, way higher than we ever were in our premenopausal years. Finally, we get that pulse. We get that boost. The egg is like, fine. We get the egg come out, but it's a much higher estradiol level because we needed much higher FSH to make that happen. So we get bigger surges in our estrogen, though the timing is off, it's delayed. And then we have a much bigger crash. And progesterone never quite gets to where it used to be in perimenopause. So she's a little slow. So timing is off. So that affects our periods in multiple different ways. Too heavy, too light, too much, too little, everything's off on the table. It's abnormal uterine bleeding. AUB is what we call it in my world. 90% of us have horrific AUB through the perimenopause transition. That's affecting our sleep. That's affecting our cognitive abilities. That's affecting our mental health. Like everything becomes chaotic. So like you said, the nervous system is like, what the heck is going on? Our nervous system thrives on uniformity, knowing what's coming, knowing it's predictable, not only in our day-to-day activities, but how our body's reacting to the normal stresses of life. And I know I'm going off on tangents here, but I get so excited.
No, I love this. You keep going.
So all of it means perimenopause, zone of chaos. Zone of chaos. Absolute zone of chaos. And when I say that, women are like, oh my God, thank you. Thank you. I'm not crazy.
Yeah.
So
yeah. And I think that, I've been saying that. I hear you saying that. We have so many people if there's one thing that women need to hear is you're not crazy. Right. When I look at the statistics on suicide, the most common time for a woman to commit suicide is between 45 and 55. And I'm like, yep, I get that.
Our SSRI use doubles through the menopause transition. Doubles. It's crazy. 20% of the population. I'm like, and everyone's like, okay, this is just, it is what it is.
Right. It's insane, which is why I hope the women listening to this, the women that follow you and me, feel like they can rise up now and speak their truth during these years instead of being gaslit and told that you should take an antidepressant. The other interesting piece that I've been really thinking about is I saw a study that showed that how powerful estradiol is for stimulating different neurotransmitters. I call it her girl gang. She's got a girl gang of serotonin and dopamine and acetylcholine. And so when she goes away, her girl gang can potentially go with her. And there's this neurochemical armor that comes down. And what I experienced was it was all my traumas, all the unresolved stuff in my life that I hadn't dealt with was right there for me to deal with. So what do we know about emotional healing during this time and what we need to do to deal with traumas?
So, I have one of the menopauses, and she's coming. I'm doing a conference in Galveston in January. She's coming to talk about menopause and trauma. And like you said, we lose our resilience. So I love how you put that. The armor comes down and all of a sudden that's why so for healing, what I've seen success in my patients. So we know that restoring the estrogen levels through menopause hormone therapy is better than SSRI at decreasing but I think there's power in revealing those traumas so that we have the space to like rectify them, because they're always kind of behind a wall. The best thing to do besides building the wall higher is to like open the door, manage them, get rid of them, right, through therapy. And so putting up boundaries, that's what I did,
Yeah, me too.
It doesn't mean I doesn't love I still love them. I still, they're still my family. This is my family I'm talking about. And
I hear you.
But I have put up walls, and I have no guilt or shame about doing it now. I used to feel so guilty when I had to prioritize my own mental health over theirs. And now I'm like, no, I have my own children to take care of. I have my own like family that I built, my own life, and this is my priority. And you are part of my life, but I have boundaries that I'm not going to allow you to cross, and that is healthy for me, and I don't have any guilt or shame over doing it. So I think that's one thing. I also, for the first time, sought therapy. I always thought it was woo-woo. I started and that therapist taught me to incorporate journaling and gratitude and, taking out time. And it's made me a better mother, a better partner, a better, and so that was really, really powerful. But it did take that armor coming down for me to realize I was in crisis mode and I could not continue, or I was going to destroy my family that I built. And so I had to get help.
Yeah. You and I feel like have similar paths through menopause and how we approached it, because, I went into my 40s like an extreme runner, like I was, marathon runner.
I was a marathoner.
And I was like paleo at the time. Like I did everything extreme until I realized it didn't work. And I had to have more variation. And then in my early 50s, those traumas that I hadn't dealt with, I felt like they were there for me to deal with. I too went into therapy and tried to work on dealing with those. And in the boundary making, in the production pace that so many women, high achieving women are at, one of the key things that I've recently discovered is that many women just aren't feeling safe. They're not feeling safe within their doctor's office. They're not feeling safe within their marriages. They're not feeling safe within corporations. And when a woman's body doesn't feel safe, her hormones, I don't care how much cream you rub on yourself, are never going to be in balance. So can you talk a little bit about, do we have strategies for helping ourselves feel safe? What can we do as women coming together to create cultural safety? Where should we speak up so that we continue to create an environment of safety for women so our hormones can balance?
So when we look at the doctor's office, this is a systemic issue and how we're training our clinicians. And, besides me educating, the masses via social media and my patients in my clinic, I'm also part of advocacy groups that are fighting for legislative change, fighting for menopause to be required study, in the medical societies, in the residency programs, and not just like the treatment of hot flashes, like it's the gender health gap, and so there are now charges leading, like we're not little men with breasts, that's Stacey Sims's, we're not little men. And, like we need to study how these drugs affect women. So that, and then train our clinicians so that a woman has a safe space to, females have a space to discuss this. And that the clinicians are trained and understand how our bodies age differently than men's, and how unique we are and how our needs need to be met individually. In the workplace, we're still working on that piece.
Right. Because that's a big one.
1 in 5 women of our age are quitting their jobs, not because of life stress, because they don't feel like they can do their jobs anymore because of the brain fog. And they're not feeling that they have a space to discuss what's going on or any accommodations that can be made. And so that is a piece we're working on as well. Jennifer Weiss-Wolf she wrote the legislation to get women's health, like more funding for women's health in general. And so she's working on tools where like we can present on social media. Here's how to write your congressman. Here's how to talk to your boss. Here are things that we can do. I think we're honestly a generation away. I think our daughters, I don't know if you have children, but I have 2 daughters, 20 and 23. I think by the time they are our age, this will be so much
Yeah.
better. There'll be no more taboo, or, it'll just be,
Agreed.
how do we most effectively allow women to thrive during this time instead of
Yeah.
her putting on armor and battle to go and get what she needs. But
Yes.
so, I think we're a generation away from that, but it's like, so we have just hacks now on ways
Right.
for us and our
Well said.
generation to kind of survive and thrive through this until we get the rest of the world on board.
Yeah, I love the way you're thinking about that, because it does take time to change a culture. Although menopause, like, I feel like we've gone from a cultural hush about menopause to a little bit of cultural chaos. Where I said to a friend the other day, I was like, do you feel like we have a lot of menopause books out? And she's like, it's so overwhelming. And I feel like the more we can unify voices, the more we can give the power back to the women that are going through the process, and let her use her own intuition as to, am I being treated right? Yeah. Like, and which brings up a really interesting point. When you're in your healthcare office or you're on your healthcare journey, where does that women's intuition kick in? Let's use you as an example. Somebody walks into your office, you give a protocol, maybe a woman, and I'm not, no criticism of what you might say, but maybe a woman's like, that doesn't feel right for me. Where does a woman's intuition need to come into the health conversation?
I think it's critical. You just need to arm a woman with information and education, and she will make good choices for herself. The end. And so,
Right.
Yes. I just had a woman write in and say, my doctor told me I wasn't having enough hot flashes to warrant treatment. And I was like, how much do we have to suffer before we qualify? It's my job as a clinician is to offer options, not to judge symptoms.
Right.
It's like really her decision. I'm just laying out her options to include nutrition, stress reduction, sleep optimization, pharmacology, supplements, whatever. And then she gets to make her own choice as to what she wants.
Yeah.
She may change her mind in 2 years. But it's not a one size fits all. It's really up to her. I don't think we do this to men. We lay out their options. They make a decision based on what they think is best for them, hopefully based on facts and not fear, and moving forward. If a woman doesn't choose to cheat, I do not lose sleep over it. That is her choice.
Right. Right.
So,
but you're a unicorn. I don't know if anybody has ever told you that.
I'm trying to create more unicorns. So I'm developing a training program for clinicians to fill in that gap that they didn't get, until we can get all the training programs on board. So, but I'm developing a training course for healthcare providers. Yeah. So they can know what I know and then help patients make better decisions.
Yeah, amazing. Going back to the 20-year-old. So one of the things that I noticed in Fast Like a Girl, I got a lot of mama bears coming to me and saying, how should my 20-year-old eat? How, what should lifestyle look like? My 20-year-old suffering. And one of the things I can say for my 24-year-old daughter and I, we've had multiple conversations over the years about birth control. And when you look at just the pill, the studies on the pill are very interesting as far as the changes they make to the microbiome are not great. And the nutrients they deplete out of our system are not great. And so I've been thinking a lot about if somebody's been on birth control for 2 decades and they come screaming into perimenopause, they're already in a bit of a depleted state. What do we need to know about the 20-year-old and the chronic use of birth control? And what would the woman going into perimenopause need to know if she had been on birth control for a long period?
So, we have the contraceptive benefits of oral hormonal contraception. And that does, because it goes through the gut, does appear to have the most disruption of the gut cycle. The transdermal, transvaginal, transmucosal options tend to be a little bit better because they just go right into the bloodstream for that. So, but I mean, good nutrition is good nutrition, and it's especially important if you're going to utilize contraception. Now it has the same effect if you're utilizing it for medical management of a gynecologic issue. And so, for myself, I was a PCOS patient. Never heard of nutritional advice for PCOS. It was birth control pills. The end. I was on birth control pills. Actually was really happy with them. But I got on these forums before the internet, so I'm old, right? And so I got diagnosed in medical school. And then I found these chat rooms back before social media, the early chat rooms talking about using nutrition to treat PCOS. And I was absolutely fascinated, and then metformin came out as a treatment option and I was like, oh, well, that makes sense because it's, insulin resistance, and I was like, God, if we just started with nutrition for this advice
early,
instead of going right to birth control pills, we could probably treat most PCOS, and use other forms of contraception. So I just think we're not giving patients the full picture because we're not teaching the clinicians, the full picture of how what the effects of these things are. I don't think we're doing adequate counseling for
Right.
I love contraception. Women who don't need to be pregnant, we need to have lots of ways for them not to be pregnant, who aren't ready for it, or this is not a good idea for them. And so I do see the backlash because we're not doing adequate counseling of the demonization of birth control pills, good and bad. I have long-term athletes who are coming in to suppress their cycles so that they're not bleeding while they're swimming, right? Like the big swimmers.
Yeah.
And because it's really disruptive for them. But also we lose a lot of testosterone when we suppress ovulation. And I'm like, that might impact your performance. Let's look at other options rather than what your girlfriends were telling you were the pill. Maybe a Mirena IUD might be a better option for you if you're looking for cycle control and contraception. Your cycles will probably go away and then you'll still be ovulating in the background. So you still have your normal hormone cycles and you get that good testosterone to keep your muscles and bones strong, and not affect your athletic performance. And I think these are nuanced conversations.
Well, and I think this is why we have to, like, you go into your 40s, you need to look back and go, what has my lifestyle been? What toxins have I been exposed to? What has depleted me? Because it's a different game once you go into those perimenopausal years, which is why I want to highlight this. The other piece is toxins. I recently saw, like about a year ago, I saw a study that in menstrual blood, they're actually measuring phthalates, pesticides, plastics, and forever chemicals. And so when we bleed every month, we are actually
a good way
detoxing.
to do it, yeah.
And so but we have a lot of younger generation that they're not bleeding anymore. And then what do we do with the postmenopausal woman that doesn't have that detox anymore? And we live in this toxic culture that we're in. Do you have any hacks or strategies you recommend for menstrual women when it comes to helping the toxic load?
I have to go back and look at that research. I haven't really, that is one area that I have very little training on, again, because it's probably newer research looking at menstrual blood and what's coming out of there.
I'll send it to you.
In the last 10 years, all I do is menopause, but I'd love to read it.
Right.
Yeah, send it to me. That's fascinating.
Yeah, I'll send it to you because then it leaves this question: if you're not bleeding every month, then you're not detoxing every month. So what strategies, I've been recommending simple things like, chlorella, of course, the fiber. I love the fiber thing because, if you feed the estrobolome, now, make sure you're having bowel movements every day. Like there's a lot, sweat every day. There's a lot of great ways we can detox, but I think we should be aware that we don't have the menstrual detox. And so I'll send you the article because I think it's really interesting. My other question is the visceral fat change. So I always laugh because I'm sure you get this. Like the videos that do the best on my YouTube are menopausal belly fat. And, I love where you're like, let's keep you out of the nursing home. Yeah, what do we do about the visceral changes, the visceral fat changes?
Dr. Pelz, that is the biggest pain point for patients. Again, they're coming from the mentality of I have to be thin, and then all of a sudden, through their menopause transition, with no changes in their diet and exercise, they suddenly develop a belly. And that gets people's attention because it's about 90% of us, and I was one of them. And I'm like, this is impossible. Like everything they taught me in medical school was calories in, calories out. This is impossible. I've changed nothing. And you go and you look at the literature and it's like, are you really only eating that many calories? Are you sure? Are you really working out as much as you thought? I'm like, I'm telling you, this is happening to me. So when you break down what is happening, so estrogen is a really powerful anti-inflammatory hormone. And when the shield comes down, the estrogen levels drop, all of a sudden our systemic inflammatory markers increase, and that drives fat to the intra-abdominal cavity. Insulin resistance increases with no changes in diet and exercise. That drives fat to the intra-abdominal cavity. Once that fat hits the intra-abdominal cavity, it is much more pro-inflammatory than our subcutaneous fat. So for your listeners, subcutaneous fat is the fat we all know. It gives us breast, hips, cellulite. We don't like it. It's cosmetically distressing, but it's a very different actor than our visceral fat. Is much higher in the neuroendocrine, production of inflammatory hormones. And so the higher our levels of visceral fat, the more likely we are to develop cardiometabolic disease. So they've measured it. In a premenopausal woman, the average percentage of total body fat that is visceral is 8%. She goes through the menopause transition, that increases to 23%.
Ooh. Wow.
It triples through the menopause transition. I don't have to tell a woman this. She knows it's happening.
Yes.
So what do we know? So HRT can help attenuate this. It's not perfect. Okay. High fiber diets, 25 grams or more, less likely you will see a decrease in visceral fat. Limiting added sugars, not sugars found in cooking, or not sugars found in natural foods, sugars put in there from cooking and processing. Women who limit those added sugars to 25 grams or less per day, much lower levels of visceral fat. Normal vitamin D levels, much lower levels of visceral fat. Probiotic diets rich in probiotics, much lower levels of visceral fat, and all the ensuing health changes. So lower visceral fat, lower hypertension, lower cholesterol, lower insulin resistance, and lower diabetes, lower stroke, on and on and on.
What levels do you like vitamin D to be at?
So in my clinic, and from what I've read, in the functional medicine world, though I'm not classically functional medicine trained, so I don't want to pretend that I am. 60 or above is what I'm shooting for, but most of my patients who are not supplementing, it's really hard to get it through our diets. We decrease absorption, all the things we're protecting our skin rightfully, from excessive sun exposure for skin cancer. And so that is leading to lower levels of vitamin D. Most of my patients aren't below 60, they're below 20. Like they are extremely deficient through the menopause transition.
Yeah. Yeah. And I would agree, higher is better. And getting it up isn't as easy as just dropping some supplements. You have to really do it continuously. That is shocked me when watching a lot of women's vitamin D levels, how some can get it up quickly and some can't. So it's a really interesting conversation. Of course, we have to talk about alcohol, because alcohol is a really interesting one, because the glass of wine becomes the thing you're like gripping to as you're going through this experience, but then it creates the lack of sleep. It creates, What would you say about alcohol in this process?
Gosh, there's nothing healthy about it, really. There's really very few benefits. For that 20-minute high, you're sacrificing your sleep, you're sacrificing calories, you're sacrificing your mental health, and I know for me and most of my patients, and I do drink, if I choose to drink, I'm choosing not to sleep. I've gotten the hot flashes taken care of, with my hormone therapy, but I still don't have the same level of sleep that I used to. I'm much more prone to have a 3 a.m. awakening, and alcohol is almost 100% of the time going to do that to me. And so I've had to make a choice between sleep and alcohol.
Yeah. Yes, I absolutely agree with that. And, Peter Attia said this on his podcast one day, and I was like, I really like this look at alcohol, which is have it hours. If you're going to have your glass of wine, have it hours before sleep. Do it with food. Do it in an environment. Yeah. Do it in an environment where you are in a social setting where it might be relaxing you a little bit, so you can have that human connection moment, that there may be a place for it, but you would need to put some boundaries around it so that you don't end up with the 2 a.m. wake up. Would you agree with that?
Yeah. So I know, so I talk to patients like, they joke about day drinking, and I love the way that Peter framed that. And like, it can be, let some of those walls down so you can have that connection or, decrease the social anxiety, but just be really mindful and keep those boundaries up so that so many of us are crossing over, and we're more likely to cross over because of the increased stress of perimenopause. And then if you're not sleeping, everything goes, it's like, we got to get sleep as a priority. And if this is affecting your sleep, we really have to look at this carefully.
Oh yeah. I have like become like crazy about sleep, where I just, nope, I cancel appointments. I don't go on social engagements, 'cause I'm like, I need sleep, or I can get a little crazy. The last thing I want to ask, and this came up, I actually heard you say this on Mel Robbins' podcast, and I thought, wow, I wish I had known this when I was in active clinical practice, which is this concept of the frozen shoulder happening to so many menopausal women. And I will tell you, what I saw in practice is the extreme worker-outers. When they hit their late 40s, the injuries were not repairing the way they used to repair. So is there anything other than awareness that might be a hormonal shift, not a structural change? Is there anything we can do for those athletic women that don't want to experience chronic injuries?
So when you start feeling symptomatic, at least Vonda Wright is kind of my go-to person. She's an orthopedic surgeon and specializes in menopause. And she says, get early physical therapy, get in there and get that joint moving as early as possible. Do not wait. We know from the Duke study, and now newer studies coming out, women on hormone therapy have decreased incidence of frozen shoulder versus women not. Also have decreased length of the time that they're frozen, and need less therapy long term. So estrogen is better at prevention than cure for so many diseases. And when we lose our estrogen, that armor against arthritis, arthralgia, and adhesive capsulitis comes down. And so many women are like, thank you, because I felt like I had broken something or done something wrong. And I'm with you. The toughest menopause customers I have are the athletes. They have the biggest mental breakdown when their body composition changes. It is so hard for them. Their nutrition, they've been running at the, and it's really hard for them to accept that all these things that kept you winning marathons and triathlons are now going to tear away at your bones and muscles. And, and we have to look at this differently. And so, and then the rate of their, once their estrogen levels drop, then all of a sudden the armor that they had against injury or old injuries is suddenly popping up.
Yeah. I would 1,000% agree with you on that hyper achiever woman. If you're listening to this, you can hear it in both of us. We've been there on many levels, and that rest and honoring the body becomes really important, not the push through grit that we learned in our 20s and 30s. It's a whole different skill set. It's crazy. So this has been amazing. And I really love the spirit in which you're bringing this forward. And I love that women are waking up when they hear you, when they hear me. My quest is for women to feel heard and seen and feel like they have a voice in this culture that we haven't had a voice. So I have to again, thank you for everything that you're doing. I just really appreciate the spirit in which you're doing it.
Thank you. Same to you.
And thank you. And then the last question, this one will be really interesting for you. I always ask every year on my podcast, I have one question that I ask. And this year I'm asking, what is your definition of health? I think too many women will say they want to be healthy, but they don't know what the definition of health is.
I think the days that I don't worry about my health are the definition of health. The days that the habits I put into place take any thought process around, I know I've got this. And so to me, good health is not having to think about it.
Yes. It's like a flow you get into. I love that. So how do people find you and your work? And we will definitely put links to your book, but where can they dive into your stuff?
So the book is The New Menopause, and it's available everywhere you can buy books. Across social media, it's Dr. Mary Claire, and just about every platform. And then we have a website with lots of great tools, freebies, information, how to talk to your doctor, how to find a doctor, at thepauselife.com.
Yeah, beautiful. Well, thank you. From the bottom of my heart, I just really appreciate what you're doing for women. And, it's just an honor to have this conversation with you. So I appreciate you.
All right. Thanks for having me.